Hello, I'm Leyfman, medical correspondent for OncLive. Here live on the floor of CFS 2024, day 2. I'm joined by Dr. Stearns, who is the Director for Translational Breast Cancer Research in the Department of Hematology and Oncology at Weill Cornell. How are you today?
I'm doing great. Thank you for having me.
Thank you for being here. We're really excited about your session on breast cancer later on today. What are you most looking forward to in that session?
So I'm talking today about some of our new approaches to treatment in triple-negative breast cancer, both in the early setting, in particular in neoadjuvant therapy, and also in the metastatic setting. But what I'm really looking forward to is the panel discussion, to hear from some of my colleagues and to brainstorm with the audience in terms of how we're going to move forward to improve the current treatment and survival outcomes of our patients.
Awesome. Looking into the future, you'll be speaking about triple-negative breast cancer. What are your thoughts on potential new targets for this condition?
So over the years, we've seen how we added therapy for these patients with triple-negative breast cancer. Of course, we improved their outcomes, but we know that we need better approaches to optimize the treatment. We know that chemotherapy continues to be the backbone, but we have several chemotherapy agents that patients are receiving. We added immunotherapy for some patients, PARP inhibitors, and so on. So moving forward, I'm looking forward to using our tools and new technology to help guide us what treatment to provide to an individual patient, how to sequence our treatment, and hopefully how to give less treatment, but the right treatment that will reduce toxicity and cost. But we have several new agents that I'm excited to discuss with you today.
Awesome. Well, that's why we're all looking forward to your presentation in the next few hours. Looking also into the future, right now, molecular profiling and biomarkers are really big topics in the field of oncology globally, but especially within breast cancer. How do you envision the use of molecular profiling and biomarkers really changing the landscape of triple-negative disease, both in the present and also in years to come?
So triple-negative breast cancer is really a group of different tumors. We call them triple-negative because they don't have the estrogen, progesterone, HER2 receptors. But when you drill down using some of our new molecular tools and biomarkers, you know that they're, again, different groups, and we might need to target and treat them differently. So what I'm looking forward to is the way we can incorporate some of these new technologies and tools to guide treatment for our patients. I tell my patients all the time that some of those technologies are ahead of our knowledge on how to use them at the point of care in clinic. I'm definitely a proponent of using these tools, testing the tumors or ctDNA and other biomarkers in tumor or blood, or even imaging or the tumor microenvironment. Eventually, hopefully, we'll find a way to package these and tell the patients what she should be receiving and how to sequence these therapies and improve survival outcomes.
Awesome. And on the same landscape of looking into the future, we're now also in the golden age, the renaissance of immunotherapy in the arena of oncology. Can you please comment on promising immuno and cell therapies in the pipeline for triple-negative disease, if any?
Immunotherapy has been a game changer for many tumor types. Some tumors that we consider more hot tumors, such as melanoma, lung cancer, some lymphomas, we've already seen tremendous benefits. In breast cancer, there have been some benefits that have been more modest and in some populations. So in particular, in breast cancer and triple negative, we use pembrolizumab in the neoadjuvant setting and also in the metastatic setting, but in the metastatic setting only for patients who have PD-L1 positive tumors. We do know that some patients have very significant benefits. Some of my work include using dual immune checkpoint inhibitors, which I believe may provide some more substantial benefits to patients. We have multiple questions to help guide future immunotherapy-related treatments or combination or cell therapy. One is, who is the right patient? Two, can we prompt the immune system to respond to our regimen? Are there other ways to make cold tumors hot? And third, what's the potential timing? Right now, we know that earlier in the course of treatment, we might get more benefit from immunotherapy. Later on, there might be exhaustion of some immune-related cells, and also that not all metastatic sites are alike. So there's a lot for us to learn to be able to know which part of the immune system you might target, what combination to look for. And I am optimistic that the future is bright and we'll have more opportunities for our patients.
Awesome. And San Antonio Breast is right around the corner. So I'm sure we're all looking forward to seeing what new developments will be featured at that meeting in the next few weeks. And so with that, thank you so much, Dr. Stearns, for your time. And for everyone at home, please stay tuned to Onc Live for the latest updates and exclusive interviews from CFS 2024. Thank you.